Hello, thank you for joining us for today's panel, Digging Deeper, Autism and Mental Health. A few access notes before we get started. Uh, there is live captioning. You can turn that on with the little CC button on the bottom. The chat is off for attendees, but we will share any links that the panelists post with everyone. The Q&A is open, though we may not have time for audience questions because we have so many phenomenal panelists and we want to make sure we can hear from everyone. This webinar will be recorded and posted to YouTube afterwards. We are recording this, and I will now turn it over to Donnie, ASAN's Inclusive Publications and Research Coordinator and our moderator for today's panel.
Hello and welcome to our panel, Digging Deeper, Autism and Mental Health. My name is Donnie Dunham, and I am the Inclusive Publications and Research Coordinator for ASAN. I worked on ASAN's report, Beyond Coercion and Institutionalization, People with Intellectual and Developmental Disabilities, and the Need for Improved Behavior Support Services. We have an amazing panel of advocates here to talk about autism, mental health care, and how to fix a deeply broken system. So let's go ahead and get started. Our first question is, could you tell us your names, pronouns, and what experience you have with mental health care for people with intellectual and developmental disabilities? Anyone who wants can get us started.
So I will get us started. Hello, my name is Nancy Thaler, and I am really pleased to be here. I use he, she, and I am a white female with blonde hair. And my background is the background for ACL, the Administration for Community Living, which is where I work. My experience is I've been working for many years, and I have been supporting people, that is providing home and community-based services for people with co-occurring conditions in many different ways. I was a direct care worker, a house parent. I ran a state agency. I have a son who has both diagnoses, that is ADHD and cerebral palsy and a number of things, as well as bipolar disorder. And currently, I work in the federal government, and I'm trying to get all of the federal agencies to understand neurodiversity and how trauma and mental health plays out for people who have different life experiences who are neurodiverse. And so I'm thrilled to be part of this panel.
Great.
I'll go next. And my name is Hector. My name is Hector Ramirez. I am Chiricahua Pasha in Mexican, and I live in the unceded territory of the Tatavian people here in Los Angeles County. My background is the CEO for the state of California, and our message of accessibility, California for all. I'm a person with a disability. I'm autistic. I'm hard of hearing, and I have a psychiatric disability. And my new kind of term of a badge of courage is I'm a psychiatric survivor. For the past almost 25 years, I have been a client with Los Angeles County Department of Mental Health, which is the largest public mental health system in the United States. And I went there as a consumer when my private insurance ran out. I'm formerly somebody that comes from our institutions, and I went from one institution to another. So I have most of my life lived in this community, both as a person with a disability and all sorts of diagnosis. It is a part of my life, but not part of my culture. And so I work really hard to fight for accessibility and equity, inclusion of not only of people with disabilities, but all of the intersections communities. And I'm a state commissioner and a county commissioner with the Commission on Disabilities, and I'm former board member of the National Disability Rights Network, which we represented all protection advocacies agencies in all states and territories. Um, I am a son. I am a brother. I am an uncle. I am a person. That's for me my most important dignity. But I'm still a person at the end of the day that has uh, who's neurodiverse, and society still constantly puts labels on me. I am now, for the first time, have full private commercial insurance, and so I've gone from going from public health insurance into private health insurance, and the difference is unbelievable. The difference is unacceptable, and the difference is the reason that I'm here, uh, to try to be able to advance accessibility for our folks. Yeah.
Thank you so much.
Hi, I'm Karen Harvey. Wow, that was wonderful too. I'm a human too. That's first and foremost. I'm a psychologist, and I've worked 38 years in the field of intellectual and developmental disabilities. And for all that time, I've been fighting and advocating for mental health treatment and for equity in mental health treatment. From in the very beginning of my career, I had to be supervised by another psychologist, PhD, and I kept saying, people deserve therapy. And they said back then, oh no, you can't do therapy. It doesn't work. So I've been fighting ever since. And I also have been studying and speaking a lot about trauma and disabilities, knowing that that's quite a reality and that people need support and people need treatment. And I am so honored to be here today. I've long admired ASAN, and I know many of you, and it is an honor to be here.
Hi, everybody. I'm Jenny, my fan. I use she, her pronouns. I am wearing glasses and headphones, and I'm wearing a black shirt. I have a stock image background with a poster that says Saigon. I did not come from Vietnam, but I am Vietnamese. My parents immigrated to the United States as political refugees in the 1970s. And I was born in California, which I grew up part of my, yes, Hector. Southern California was where I was born, but I grew up in New Orleans, Louisiana, and then ever since I've moved around so many different places. So in terms of access to healthcare, mental health care, I have experienced it in multiple states as a patient and also as a mom of 4 children. 3 of my children are neurodivergent, including autism, ADHD, and intellectual disability. And through my parent experience with my children, I discovered that I was autistic and was diagnosed after I completed my PhD. I suspected that I was autistic prior to completing my PhD, which was a study on autistic adolescents and mental health. But because I lived in a state that did not have access to being seen as an adult, that they only saw children for an evaluation for intellectual and developmental disabilities, I had to wait until I moved to a state that I had access to a diagnosis. So not only is this topic personal to me because of my own lived experience, my children's experience in navigating the healthcare system for them, but also because I am passionate about this as a researcher, that I studied this for my PhD, and I'm currently doing this work now. I believe that adolescence is a very critical transition period for many people, many humans. And if we can figure out a tailored, uh, appropriate way to support our young people during this transition period, perhaps maybe that their adulthood would be healthier and their quality of life would improve. And so that is why I target that developmental period in my work.
Thank you.
I'll jump in if that's okay. My name's James Baptiste. I use he, they pronouns. Not sure what parts of myself to introduce, but I've been working in the mental health field and human services field for about almost 10 years. I personally identify as someone with a mental health diagnosis. I was actually very recently updated on what my diagnosis is last week by my therapist, and I've been navigating the mental health field since I was about 15 years old. For some time, I worked as a mental health counselor, and I provided support groups for a lot of different people. But that is a little bit about me. I'm also very, very, very honored to be here. Thank you so much for the opportunity.
Thank you for introducing yourself.
My name is Perry Spencer and my pronouns are he, him. I'm an autistic person with severe mental illness that has resulted in multiple psychiatric hospitalizations. I'm passionate about access to home and community-based services and giving people with developmental disabilities choices and support to live in the community. I serve on the Lake Center Steering Committee. The Lake Center is working to improve education and access to services for people with IDD and mental illness. I'm a white person with short light brown hair wearing a yellow and blue striped shirt. My background is yellow curtains. I'm rocking back and forth.
Thank you all so much for introducing yourselves. I want to move into our next question. Why does it tend to be more difficult for people with intellectual and developmental disabilities and mental health disabilities to get mental health services?
This is Hector. I'll jump on that one. It's an issue of accessibility. It's an issue of recognizing that mental health or psychiatric conditions are disabilities and that they are just one of many disabilities. So oftentimes the system not only segments us because that's historically has it been supposedly for billing, but it has created different types of populations. We have the people that go to commercial health, the people that go to regular doctors, the people that go to psychiatric doctors, so mental health clinics, and people that go to, other clinics that we're supposed to go instead of just having the availability for us to be able to access care in any of those settings. People believe that we're supposed to be different and they don't understand our communities. It just doesn't comprehend to a lot of folks what a disability is and what accommodations are. And having worked in one of the largest public mental health systems in the world, I have seen that when our community members come looking for help, our folks are just either supposedly unfamiliar with our population or they don't know how to serve us or provide accommodations that they turn people away. And in the Los Angeles County where I live, if you happen to be an individual with a disability, you're more likely to get shot or killed by law enforcement while trying to access mental health services. That statistic goes up more if you're a person with autism or an intellectual disability for some reason. And we know that the reason for that is because our service providers and our emergency system staff just struggle to understand how individuals with intellectual developmental disabilities can access mental health services or how we can even benefit from that. And because they lack that general understanding, they just assume that we are somebody else's responsibility.
If I may chime in here, also, Hector, I think part of the issue is in articulating mental health problems that do not neatly wrap up in a nice box called anxiety or depression or PTSD, how can people with intellectual developmental disabilities list out symptoms of mental health disabilities without any training in mental health disabilities? In reality, it is usually loved ones who identify those mental health symptoms and then seek support for people with intellectual and developmental disabilities. If we're talking about young people with IDD, are they getting this education? Are they filling out these pediatric questionnaires that survey for depression, anxiety, and suicidality? Or is it their loved one who is filling those forms out for them? And the other way to think about this too is mental health services are more reactive, less proactive. They are sitting resources. People have to seek that resource in order to get the service. For people with disabilities to seek out this service, there needs to be a pipeline that brings them to these services, not more referrals. How many of us have been through so many referrals? And then in that pipeline, it needs to be customized to fit the person's unique needs. If we're relying on a loved one to introduce that pipeline to people with IDD, then we have to improve the methods of service delivery. So for example, it could include creating a treatment plan for say, depressive episodes, panic attacks, suicidal ideation, so that loved ones can better be prepared on what to do in case they need to take action. And then this treatment plan has to be shared with people with IDD so they too can prepare themselves in the case that they need to. And then in that treatment plan, there could be sort of an SOS signal that they could use to communicate with each other. And these are some strategies that mental health services can work on together with clients or to share freely to the broader community. This is just one example. But if we're thinking about people with IDD making their own choice to self-select what is it that works best for them, then we have to improve our education system, right? So we got to teach young people in schools about mental health that is inclusive of IDD and not just about mental health. And if we're talking about students with IDD and special education classes, they have to receive this education in those classes too. I know not all students with an IEP sit in gen ed. Some might sit in a special ed classroom all day. So that's why I bring that up. You know, in this education, students need to learn causes of mental health problems, such as neglect, abuse, trauma, stress, bullying, family history, fill in the blank. They need to know where they can seek mental health services confidentially. This could mean that, I guess I'm getting into the policy part, which I'll kind of briefly talk about, but it does mean policy change is needed to ensure that students are getting this service from well-trained people for free for the students at least, not so much for taxpayers. But as of today, they're getting supports through school counselors. They're expected to provide this service in schools. How's that working out? Is it working out across all schools? And do school counselors have anything to say about this? What about the students? Do they have anything to say about this? Is there even an evaluation or feedback process or even follow through? So these are just some questions that I've personally experienced and also have heard many parents talk about and bring up in regards to supporting their kids.
Just to add to what Hector and Jenny just shared, when I used to work as a mental health counselor, I witnessed firsthand, because a part of my job was information and referral. And I would witness firsthand, countless people coming in saying, hey, like I need therapy. I would really like to go to therapy. And I would look up therapists that accepted their health insurance, which was typically Medicare or Medicaid, and just time and time again coming up without anything other than local clinics. By the way, I'm in the state of New York. And clinics are great, as a sometimes, depending on if there's high turnover rates and stuff like that. But then you refer someone to there, and sometimes there's never a follow through, not from the person that you refer, but from the agency themselves. They don't follow through because there's not enough staff to meet the demand for mental health services. And then, you look for another place, like I don't really know how to describe what my job was, but we did support groups. We had art classes, community-based trips, a lot of different resources basically in this one building, including case management. And a big part of our thing was wellness activities, and wellness activities could be a variety of different things. Um, and we had a person come in who was on the spectrum, and one of my coworkers was very adamant about saying, this person, I can't support them. They need a one-on-one. I can't do it, and was very adamant about I can't do it, and never questioning how could I modify what I do already to make sure it's more inclusive. And I feel like a lot of the time, people with IDD or mental health diagnosis are often separated, instead of looking at it as something that could be seen as a bigger picture. Um, one thing I learned when I was in school is like meet people where they're at, and I feel like that's not very common, unfortunately, in the mental health field, especially after working in there for a while. It's just not right. It's not equitable. It's not fair. And yeah, I thank you both for what you shared so far.
Couldn't agree more with all three of you. And I forgot to describe myself. I'm an old lady with reddish brown hair and a pink room. So I I have heard from so many therapists and so many families and so many people with disabilities and provider agencies that they've sought mental health treatment and they've been told by the therapist, can't do it because I'm not trained. And I just think that's a horrible travesty. That is so unfair and so wrong, because there is no training. So my response is always, are you trained in working with humans? Because then you qualify. But exactly as James said, I've had that response from people. And, this is ableism, and it's ableism in the mental health world, and it's a barrier we have to break.
This is Nancy. I'm going to say something that might sound a little negative or controversial. But for starters, I'm not all that impressed with services provided by the mental health systems in general, whether people are neurodiverse or not. And this is especially true in the publicly funded, if you're using Medicaid or Medicare. Those services are all delivered through organizations, and the organizations really don't keep up with best and promising practices. And they also generally grossly underestimate both the experience of trauma in people's lives and what that means, and they also grossly underestimate the trauma that one experiences just through neurodiversity, the fact that sound can be overwhelming or touch can be overwhelming. And so I was a state director of disability services in Pennsylvania for a long time, and I kept saying, all I want is for our folks to get what everybody else gets. And then I realized they were, and it wasn't very good. And so it's not off the shelf. So I think that I'm going to talk about publicly funded systems and assume that most people are getting Medicaid in some way, shape, or form. So excuse me if it doesn't address everything, but in the Medicaid world, we need for our state Medicaid agencies, mental health agencies, and developmental disabilities agencies to be on point about this, to understand that whether someone is deaf and cannot hear, or they're neurodiverse, or they're older and have dementia, that those present unique needs, and we need practitioners and professionals who are multilingual, who understand all those experiences and can shape mental health treatment to the person. And so I could write up what is the ideal way this should be done. We are really far away from that. Now, I will say the good news is, unlike 1971, when I got into the field and the standard belief was that you couldn't have an intellectual disability of any kind and also have mental illness. These were mutually exclusive. And that drove state and federal policy until very, very recently. We now have state agencies across the board understanding dual diagnosis, as they call it, which is also something that refers to drug and alcohol and substance abuse and mental illness. But they get it. They just don't know what to do. And so, admitting there's a problem is a huge, huge step forward. Admitting they don't know, but that I think opens the opportunity for people with lived experience and who can really effectively articulate that lived experience and what would help. The doors are open for you to make a difference. I mean, that's the Link Center opened up the door for members of this organization to be on the advisory group and participate. So I think that the focus has to be, how do we get people in charge, people in policy roles, people, the payers, to understand exactly what would help so they pay for the right stuff and not the wrong stuff. And by stuff, I mean people who can do cognitive behavioral therapy, dialectical behavioral therapies, individual therapy, group counseling that work for people with unique needs, and also pay for peer support, which is a very powerful way for people to recover or to cope with. And then lastly, a bunch of therapies that they don't want to pay for that are really important, like equine therapy and music therapy and mindfulness training and transcendental meditation. There are all these other vehicles to calm the nervous system that are effective. So I think we know what works. We just have to get the people who pay for it to pay for what works.
There are tons of reasons, unfortunately. A major issue is that mental health professionals don't have training or experience working with people with developmental disabilities. For example, someone without experience with speech loss or non-speaking people may assume that a person who is not verbally speaking is being non-compliant with treatment when in reality they are unable to communicate. Even more stigmatized mental illnesses, they may not have adequate training. I have dissociative identity disorder in addition to more common mental illnesses, and not even taking into account my autism and transgender identity, there is no one in the state of Kansas where I'm from that's qualified to work with people with dissociative disorders. That takes new patients. Another issue is everything being blamed on the developmental disability instead of figuring out what is actually going on. For example, an autistic person's self-injury starts increasing and people blame it on autism, instead of figuring out what's happening with the person causing them to be so distressed in a way they weren't before.
Oh yeah, and one thing I want to add to like what Nancy said about people being on Medicaid or public insurance, like sometimes even getting on the public insurance is like a step like that people don't have access to. Like in the state of Kansas, Medicaid has not been expanded, and you cannot get Medicaid, which pays for home and community-based services through the waiver, to like if you are not on disability payments, so SSI, SSDI, if you don't have children or dependents. So if say you're a single person with a disability who is able to work part-time or is not eligible for disability benefits, you are not able to get on Medicaid, and then you may not be able to get the services you need, especially the ones that are paid for through the waiver.
Thank you all for your answers. Those are all such huge barriers to getting care. Our next question is, what do you wish policymakers and advocates more broadly knew about people with IDD and mental health disabilities? Are there issues you wish they would work on more often?
I'd like to jump in again. Also, I realized I did not describe myself. I am a biracial person, bald head with a beard and glasses. Um, right before I left my job as a counselor, I was working with someone, I'll give him a fictitious name, Tim. And I was working with Tim. One day, my boss said, "Hey, can you reach out to this person?" They called looking for help with case management or something like that. So I gave Tim a call, and I'm talking to Tim, and Tim tells me, I have an intellectual disability, and he tells me that he's in his 60s, his mom's in his 80s. And as I got to know him and try to connect it, like figure out what it was that he needed, I learned that he was living in a motel. So he was bouncing from motel to motel, using his entire Social Security check to pay for said motel. His 80-year-old mother was working part-time jobs to help pay for this motel. He had no access to transportation, was unfamiliar with the bus routes because when you go to in New York, when you go to like social services, at least in my area, they kind of place you in any motel that's open or available, regardless of your knowledge of transportation in that area. And so he was placed in this random motel, uncertain of how to read signs, because as he told me, he's like, I can't read. Um, so doesn't know where he is, doesn't have any much money, is literally and like I was familiar with the area, so I knew that the motel he was describing was on a main highway, so in a dangerous area, and not really much of a support system other than his mom. So if I were to be speaking to hold policymakers, I would really emphasize housing, and community, because imagine, maybe he is experiencing homelessness right now, but at least he has a community where if his check runs out, if his SNAP runs out, he can say, "Hey, can someone pick me up and we can get food together?" Or can someone pick me up and bring me to where I was currently working, because I was trying to, in order for me to process the paperwork, I needed to get his signature on everything. But I also couldn't travel to him because he couldn't tell me his exact location. So there were so many barriers and obstacles trying to get him the support that he needed. And unfortunately, I don't really know how, his story continued. Eventually, I did manage to get the documents I needed signed so I could speak to the county and see what resources existed for him. But it was weeks, like it took a very, very long time. And at some point, he kept calling me and I kept giving him the same answer, and he was getting really frustrated and honestly, most likely triggered by my response. And my response was always the same. I'm sorry, Tim. I'm trying my best. I'm processing the applications. I can't do anything more. And it just like all the stories that he was getting reminded of. And triggered by this same exact thing that I was doing to him, that the system had been doing to him for years. So I rambled a little bit, but in short, I would tell policymakers that we really have a housing crisis, and a huge lack of community, where people are just isolated from one another. And yeah, I still think about it. I hope he's doing well every day. But yeah.
Wow, that's such an important story. Thank you, James. It says so much. The one stigma that has just torn me up for the entire time that I've been in this field is that people are labeled by their behavior problems and not by their mental health needs. And we don't look past that. There's a whole behavioral approach that is dehumanizing and stigmatizing. I'm thinking of a young woman I work with who was in a lot of pain and was cutting herself. And that was called self-injurious behaviors. And she's doing it for attention and she needs a behavior plan rather than here's someone in pain who needs support and needs therapy. And after several years, it took a long time, but of working with her in therapy, she's now working, she's now doing all kinds of things. And it wasn't never about attention, and it was never a behavioral issue. It was her pain from years of trauma. And people are so misunderstood, victims are blamed, and people are stigmatized. When they're smart, they're just suffering. And IQ has very little to do with intelligence and the emotional depth of people with disabilities. And that's just the reality.
And this is Hector. I'll continue the conversation, and really want to uplift what has been shared. And I didn't describe myself other. I have long hair. I'm almost 50, and I'm wearing Avalon shell earrings and orange shirt. Orange is my favorite color. Orange was a very stigmatizing color growing up. I come from state hospital and developmental centers, and saying that orange was your favorite color meant that you were mentally ill. It was part of our diagnosis criteria. And so I stopped telling people that I loved orange, and it's my favorite color. So now I wear it every day. And it is the stigma of just being who we are that has perhaps been the most important thing that I want people to understand, policymakers and advocates. It is a shared stigma, whether you are labeled as having a severe, persistent mental illness that leads into conservatorship and you get your rights takes away, or if you're considered to have a profound, severe developmental disability, that you're so intellectually disabled that again you are conserved. We share a similar fate in this community, one that goes back to state hospitals because that's where they used to put us together. You had the crazies and the R's. We were together. We still live in the consequence of that stigma that unfortunately it's also driven by the places where we go for care. The institutionalization, the Western model that we still have, the over necessity for the diagnosis to be able to access supposedly funding for services that are not there, that sometimes just do more harm. It's part of the stigma that continues. And that's why uh, really bringing uplifting information and humanization of that is still something very important. Our homeless epidemic is based on stigma. Here in California, 40% of our unhoused individuals are people with disabilities. And the reason for that is we get stigmatized, we get punished, we lack access to justice. It is considered the standard quo for people to think that we are crazy, that we are not smart enough. That is a shared stigma that society puts on us, and that is a constant battle that I think fuels a lot of the policies that we have, where businesses get run up by politicians because there's too many homeless people outside, and we're robbing, and the reality couldn't be further from the truth. It is a narrative that has existed for quite a long time. It is based on racism. It is based on sexism and ableism. It is very much alive, and it's one of the reasons that why so many of our community, when they go and try to get mental health services, they get hurt more. They continued overgeneralization traumas in our communities is shared in our disability communities. We might not be related by blood, but we're related by diagnosis. We are related by diagnosis. That's how we are related. Not by our last names, but where we were placed on the DSM. And I remember I think it was almost 10 years ago when the DSM was going to reclassify autism. And I was very into psychiatry, but I joined that fight to help expand the diagnosis because I knew that at the time that diagnosis was only given to take our rights away or to force medicate us. But I knew that expanding the diagnosis would mean that other people who didn't have access to care and services perhaps could do it more. And I've seen that change dramatically since the diagnosis for autism has changed. And I think, again, that comes by changing the narrative, changing the words that people have, questioning them in public, define them, and redefining them. Asan has done that for our community so much, which is why I'm so glad to be here. And I think that is a thing that our peers do. nothing has been more better for my mental health. I have been institutionalized so many times and have had to be in the hospitals. The thing that helped the most was being around my peers because I felt human. I I felt okay. And there's no medication or therapy that does that, and I think that is the one thing that we're still fighting for. All of us are struggling to survive in this difficult world. The rent is too high, the weather has changed. Racism and sexism are real, folks. Many of us feel it the minute we open our eyes and the minute we close it. For many of us, that is a reality. For people with disabilities, the lack of autonomy, safety, and independence is more than enough reason to drive us crazy. Okay. And so I think right now what is happening in our communities is we used to be put away in state hospitals and mental health capitals, and now we're coming back again together. In my mental health spaces, I'm hearing more and more people talking about having disabilities. I'm hearing more and more people talking about having autism. I'm hearing more and more people about talking about being neurodiverse. And I am just setting the room on fire when I hear that because I want people to hear them. Because I remember and I know where we've been. And being in California, where we have the slippery slope of disability rights, I know that institutions are back on the table. I know that restricting rights are back on the table. I know that forced medication is back on the table. I know what's at risk. And I think when it comes to our advocates and our policymakers, the thing that I wish they knew is that not only they listened, but they heard. Where we're in the room and we're taking up space, who we are, and just kind of recognize and reclaim our humanity. That is the one thing that I want them to work on.
I want to also follow up to on Hector's point about 40% of the unhoused or homeless individuals in the United States have some form of intellectual developmental disabilities. About 4 to 10% of adults with intellectual or developmental disabilities are currently incarcerated in the United States. And that's an overrepresentation considering that people with IDD are about 2 to 3% of the US population. So when we talk about getting the attention of policymakers and advocates, we're talking about adults who are without a home, or if they are housed, they're housed in prison and they're not getting rehabilitation or any supports, or they haven't had it, and why could potentially explain why they are in the place that they are at. And as I mentioned earlier, I'm a huge youth advocate. And if we want to think about setting people on the path for better quality of life, good health, we have to think early. So if we're starting with services in adulthood, which is great because that is a need. It is a huge need. We are in crisis. We should absolutely focus our efforts towards adults. But let's not stop there. Let's get policymakers to think sooner than that. Because if we don't try to think about how to intervene sooner, this crisis is only going to get worse. And it doesn't need to be anything big. It could simply be change and reform in education policies. If we could just add into school curriculum better understanding of the intersection of mental health and intellectual and developmental disabilities, make it inclusive so that young people have this understanding and know how to better advocate for themselves. We don't have to wait until we're 18 when we can vote to spark change and speak up. We can speak up before we can vote, and we can inspire people who can vote to then go and vote and make a change. So there are many issues that we can be concerned about, but let's not forget the young people when we're trying to shape policies.
there are a couple of questions and answers, two of them in the list. I have some thoughts on them, but would defer to anybody else who wants to speak to those two questions.
We will get to the Q&A after we finish just the prepared questions, but
Thank you.
I need people to understand that dual diagnosed people are at a higher risk of institutionalization than people with just IDD or just mental illness. When I was homeless, I was hospitalized twice in 3 months and discharged to the homeless shelter. What I needed was housing and support, not control. I also want people to know that we deserve the right to choices and autonomy non-disabled people have. I think we need to fight for mental illness-based home and community-based services. There are very few options for people with mental illness that aren't only meeting with a therapist once per week or hospitalization. We need to expand wraparound services for mentally ill people so that we can remain in the community. Also, we need to increase competence in developmental disabilities to providers at all levels of the mental health system. We also need to work hard to eliminate waiting lists for home and community-based services that already exist. In the state of Kansas, people can wait 10 years to get funding for IDD home and community-based services. I have been on the waiting list for 3 years and still don't have funding, which also means I'm unable to leave my family home and move out because I don't have necessary support with daily living. This is especially impactful in situations where the disabled person unable to leave is being abused. Ending waiting lists is life-saving. People die waiting.
And this is Hector. I'll add something while I don't know if, are we still waiting? Okay.
Thank you, everyone. We are now going to move into our last scheduled question. Then we will get to audience questions. Our last question is, what are the consequences of people with IDD and mental health disabilities not being able to get mental health care?
Hi, this is Jenny. If it's okay for me to go first, everybody. So what I'm about to say might not sit well with people. It is coming from a place of frustration and disappointment that we have barely moved the needle in mental health care for people with intellectual and developmental disabilities. I can speak in terms of the bottom line or how it affects employers' profits if it gets the attention of policymakers. So lack of mental health care for people who need it sinks productivity. Work progress gets delayed, employee turnover rate is higher. Without mental health care, it can lead to burnout, and the recovery process might take a long time. People will need to take sick leave due to neglected mental health care. That's just, speaking in terms of people who are employed, not even speaking to people who are unemployed. And then to also think about perhaps, let's not forget loved ones who are affected too. So if you're someone who struggle with depression, anxiety, PTSD, and you live with family members or you have children, they're affected too. It's not just unique to you, right? we don't often talk about our mental health problems that can affect mental health problems in our loved ones. So treatment is the antidote for preventing shared mental health problems with our loved ones. This is a societal problem. So this is why I'm speaking to the bottom line and how it affects people's bottom line and also their productivity. It's especially difficult for an unhealthy person to support another unhealthy person. It's almost unfair, and yet it happens every day and everywhere, and this cannot be our norm. So mental health care parity is a must. Right now, many people are trying to find different ways to get mental health care coverage in whatever means that they can. But mental health parity is being trumped by policymakers in certain parts of the US instead of expanding them, such as what Perry was saying earlier in Kansas with Medicaid policy change that is restricting mental health parity in certain parts of the United States. So that we're going in the opposite direction. We're going backwards instead of forward. That's part of the problem that contributes to so many of the topics that James mentioned, that Hector mentioned, that Karen and Nancy mentioned as a society that we're facing right now in the crises. So that's why I speak to people's bottom line.
And this is Hector. I'll share my last words. And I remembered of a story. It's a story that I've heard many times growing up. I've heard it in many different languages. And pardon me if you heard it differently. And he goes, "This is a story about four people named everybody, somebody, anybody, and nobody. And there was an important job that needed to be done. And everybody was sure that somebody would do it. Anybody could have done it, but nobody did. Somebody got really angry about it because it was everybody's job. Everybody thought anybody could do it, but nobody realized that everybody wouldn't do it. It ended up that everybody blamed somebody when nobody did that, when nobody did what everybody could have done. And I think this is an example of what's going on right now. Uh, it's an issue about access. It's an issue about doing the right thing. We know that not providing people with intellectual disabilities and developmental disabilities the same equitable access that everybody else has to mental health services because of our disability is a civil rights violation. It is a federal civil rights violation. It is a violation of a state, of a county, of an agency that receives state and federal funding to provide health service. It is a violation of their contract. If they are a licensed clinical provider and they are denying individuals with intellectual and developmental disabilities, we know that it could be a violation of their state clinical license. And we need to call them out of it. We need to call our clinicians. We need to call out our departments. We need to call out our regional centers. We need to call out our states when they don't follow the law and they deny people access, timely access to equitable, safe, self-directed health services because of our disability. That is a disability. That is discrimination. We don't tolerate people being discriminated access to healthcare because of their race, right? None of us would put up with that. And we're fighting like hell right now because we know that women, you should not be denied access to healthcare because of your gender. Why are we tolerating the status quo to allow that people get denied the same type of access to care just because of our disability? It is unacceptable. And I think that's what agencies and departments need to understand. Here in Los Angeles County, our departments, our county are paying a lot of money in settlements because of people that have been wrongly hurt, shot, paralyzed, killed, people who have unfortunately died of suicide while begging for help. And they were turned away. And it's costing our municipalities a lot of money that are needed for our community, that are needed for people in need right now. We have an epidemic and many different things. And instead of using our resources to solve that, we're trying to cover the back end of the damages that have caused because we denied people access because of who they were. That is what I want them to understand. That happens when people are denied access to care. Not only does it affect us economically, humanly, societally, it perpetuates a type of abuse that it is intolerable and has consequences. And I am starting to really just continue to point that out to folks because it is a bottom line of dollar. It is election time, but it's also moral time. And sometimes it's not about what others' moral choice is. It's about us and speaking up and not allowing this to happen to us, but not allowing this to happen to our relatives, whether we're related to them by last name or ethnicity or by diagnosis. You know, we have to speak out for each other. And that's what I want people to know, that we are speaking out like we're doing today here. By being here today, you're being witness to what's being shared, and you'll share it. And that is part of what we're doing when we take up space and we go and we to those politicians and we take up those space and we share those stories and we demand justice, we demand access.
The biggest problem I have had when not able to get routine mental health care is the increase of meltdowns and crisis related to my mental illness. This leads to self-harm, intense suicidal thoughts, and an increase in institutional crisis stabilization services like forced or coerced psych hospitalizations. The amount of self-injury goes down when I have long-term access to therapy and medication management. Also, IDD systems get even more overwhelmed and overburdened because mental health systems are pushing everything onto IDD systems, even if it is something the mental health system is supposed to provide. Instead of IDD and mental health systems working together in a collaborative approach, they just pass the buck, and the real loser is the disabled people they claim to support. I also want to say that the services that are available are very coercive. I think the reason is because of the dark history, and in many cases present, of both IDD and mentally ill or mad people have with institutionalization. For centuries, if you were visibly mentally ill or developmentally disabled, they would shove you into an institution to torture you and make you comply, all while calling it treatment. To this day, there are people living in state hospitals and nursing facilities. It has only been 25 years since the Olmsted Supreme Court case gave disabled people the right to receive services in the community instead of in institutions. The compliance-based quote treatments quote of the medical model live on. Because the goal of the mental health system as whole is to make someone's madness palatable so they can be useful to capitalism. It isn't about reducing the person's distress and making our lives easier. It's about making us compliant for the comfort of non-disabled people.
Exactly. Thank you for saying that, Perry. Thank you for saying that. And thank you, Hector. This is so true. It is a gross human rights issue. And there are still so many people in institutions, so many people without rights, so many people without choices, and not getting mental health treatments. And there's a lot of resources being poured into behavioral treatments that are actually dehumanizing and sometimes re-traumatizing. And those same resources need to be put into, as many of you pointed out, training the therapist, giving the therapist that comfort level, peer supports, all the things, as Nancy said, that we know work, but redirecting those resources and re-examining what we're doing. Thank you.
Would anyone else like to share?
I think one thing I'd like to add to what everybody said, which everyone said such amazing things, and I don't think I could say any summarize it very well, but um, when we're not addressing mental health issues, we're also, contributing to people's physical issues. So for example, when you're not addressing certain mental health issues like anxiety, then you can have a bunch of other health issues like IBS, immune system issues. I'm looking at my notes here, inflammatory responses. If you have depression and that's not being addressed, you can have issues with diabetes, heart disease, stroke. When we're not looking at the full picture, we're leaving out so many things that can just contribute to other issues in people's lives. Um, and then, in the most severe cases, homelessness, incarceration, death by suicide, and then a continuation of being traumatized. If you don't know that you have mental health triggers, then how are you supposed to work on those triggers? And so then, as others have said, it just perpetuates this cycle of just not getting help, and it's just not comfortable, and it's not right that people have to continue to live in discomfort because there's an issue with recognizing more than just one thing. But yeah, everybody said really great things.
I just wanted to add to that it wasn't until recently that the National Institutes of Health considered people with disabilities as a population with health disparities for research fairly recently. And I think that there has been research efforts to study mental health and intersection with people with intellectual developmental disabilities. Of course, there's plenty of research on that. But for people with disabilities to be classified as a population with health disparities, to James' point, right, that there are co-occurring medical, physical health problems that we experience because we're overlooked when it comes to diversity, equity, inclusion initiatives. And it wasn't until recently. So, what we can expect is for probably the next 5 to 10 years, these problems will continue to exist because research, science, policy, government takes a long time to take effect in their policy changes and in applying research results. And so, how can we move the needle faster than the slow move that we've been seeing for decades, forever, right? It's to Hector's point, is that we band together and we see each other with these diagnoses as our neighbor, as friends, as our community, and that we support one another. I don't think that I could be where I am today if it wasn't for my support community and knowing that I'm not alone in navigating these siloed systems of care that are just overwhelming. And sometimes I just don't even want to deal with it because it's just too much to deal with. But I'm not alone. I have a community and I'm very grateful for that community. And we do need to speak up and to not stop. We got to keep speaking up.
And this is Hector. Yeah, I think we need to speak up a lot between now and next month, where a big decision is going to happen. In the previous election, we knew how, in our previous administration, we saw how our community was severely targeted and defunded and disassembled our civil rights department. One of the reasons that the Homestead Act is really not enforced for most of the United States is, there was this disassemble of our civil rights systems and our agencies, and so we lose the potential of going back in a couple of days at the election. So I think, right now it's another reason why we need to let people know why we are so important to our community, particularly for the mental health. I have, in the 25 years that I was with my community, I'm very active with my peers. One of the things that I saw so useful was having our autistic and our neurodiverse community come in, and it has been healing for our folks who have supposedly severe persistent mental illnesses like psychosis to have conversations that are embracing of them, that are accepting of them. And I have never seen more proof of how therapeutic our peer workers are than when I see our autistic folks working and really helping our supposedly severe schizophrenic and bipolar folks, because they treat them like human beings and they're able to really address the bottom line problems. They can't find a house, they can't keep a job. People discriminate them on a regular basis, and wow, to see our communities just kind of working together right now in that space, for me, it's been really exciting because I see our younger people coming to spaces and having new conversations that I never imagined we could have about our community, and seeing scientists, the fact that we got the health disparity, assignment so that we can do research was so big. And we have our scientists and our autism activists to thank for that, because they have been doing a lot of these tough conversations, going into hard places where they say horrible things and really, really advocating. And so I just kind of excited about that as well, because I know I've been taking like a lot of down, 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 but the reality is that we have a lot of up, up, up movement. Like here in California, now if you're under 18, you no longer need a diagnosis to go get mental health in schools. You know, we have CHIS, we have Medicare expansion. Hello, we fought for that. So we're able to really expand our services. We now have peer certification. And for the first time in the United States, we were able to get billing and reimbursement for our traditional native healers, for our communities, so that we can expand access and modalities of care that we know work for our communities that are traditionally there. In my native community, we've never had the word disability, but we have existed. We have existed along, and we've played roles, we have traditions, we have a purpose. And kind of seeing that conversation come up again and being funded is really giving me hope. So I just really want to add something positive to it too.
This is Nancy. I think if you haven't seen it, I should make sure you get a copy. And it is a letter that the Center for Medicare and Medicaid Services sent out to all state Medicaid agencies, specifically about implementing the EPSDT requirements in Medicaid, the early periodic screening, detection, and treatment requirements, that all children must get all services they need in the Medicaid program, whether adults get them or not. And mental health is a big part of this letter. And it says explicitly in the letter that states cannot eliminate or make ineligible children who have an intellectual disability, but they must be treated equally. Is pretty exciting. And I will tell you, the agency I work for, the Administration for Community Living, worked to make sure that was in there. That's what we do, advocate within the federal agencies. So do you all have that letter, or do you need me to send it to you?
And this is Hector. If you could send it, I know that the administration this year has done unprecedented work for the disability community, and yours is one of the ones as well that I want to share. But we have had historic unmonumental move in updating of disability laws and regulations. So thank you.
Nancy, if you send that letter to Dean, we can make sure the other panelists get a copy.
I will.
Thank you everyone for your answers. This has been a really great panel. I want to move into our question and answer time. Our first question is from an audience member who writes, "My son is an ABA survivor with PTSD. Inhumane compliance training is not mental health care, and parents are not given informed consent around this intervention. Are any of you advocates who speak out against multi-billion-dollar ABA industrial complex? I think we can broaden that a little to ask about people's thoughts on how we move from a behavior-based system to a system that actually recognizes mental health."
This is Nancy. That's a courageous question, and it will take courage to respond to it. So I, for one, am on board with your point of view. One of the challenges in trying to make people put ABA in perspective is that it is so overwhelmingly supported by families across this country, to the point that there are a number of states that have passed state laws mandating insurance companies to pay for ABA. And it has come to a point where autism equals ABA. And in some ways, it's been an easy out that when people say you need to meet the needs of people with autism, we provide ABA, job done. And so we're beginning to crack that some by showing all the other things that help, like somatic treatments, et cetera, and by teaching that ABA doesn't factor into trauma most of the time, and that's a big weakness in it. And I wondered whether we were having an impact, but the other day I subscribed to a lot of emails from the industries, the managed care industries and the investment equity companies. And this week, and there's one specifically for autism programs, because it's big business and there's big money in it, and they're buying out all these companies that do ABA. And the last one I saw early this week said, we got to do more than that. That autism is about more than it. So the equity investment companies somehow are getting the message that it's not just ABA. They are, the way they're in this email communication among the companies, what they're thinking about is broadening the range of services they provide, including becoming physical health providers. So they know they got to do something more. I'm not sure they know what it is, but somehow the message is getting through. And I have to say, the voices of people on the spectrum who talk about this from a personal experience and who can teach what would have helped instead of ABA, will push this forward. So whenever there is an opportunity to speak of this, to insert it into some presentation you're doing, I think the more people say it, the more it gets out there, and we will begin to change the paradigm and the thinking. But right now, to just publicly oppose ABA or to come out and say, it doesn't work, it is, that speaker will be drowned out and punished. And so we've got to find a way to change the culture and the profession in a constructive, informative, and an advocacy kind of way.
Can I add to that, if that's all right? So I did not mention where I work, but I work for the National Alliance for Direct Support Professionals. And something that we really, really value is we're trying to build a more competent workforce that's with where they have the competency, the knowledge, but then they also have the value and the skills. And a few of the tenets that we have is person-centered supports, advocacy, self-determination, and promoting physical and emotional well-being, right? To, hopefully I'm answering your question all right. But if we want to move away from an old system, then we have to have a more competent workforce, right? Like we have to have people who know what they're doing and have the confidence to continue doing what they're doing. But they also need to have ethics and values, right? So if we want this workforce to be more knowledgeable on mental health services, then we need a more consistent workforce, right? To navigate the difference between a stimming behavior, an ABA behavior or, a trigger or a trigger or trauma response, right? But you can't really have that if there's such high turnover rates within the workforce, because how are they supposed to notice the difference if they're just now joining the team? But then the same thing is documented in their chart. Let's say every time broccoli is served, they go and they have a crisis. And it's like, well, maybe there is a story there with the broccoli, but they're never really going to get to know that because all that's documented in their chart is they do not like broccoli. But maybe there's a story tied to abuse, or maybe that's all that they were fed, or whatever, what have you. Or maybe broccoli makes their mouth itch and they can't really communicate that because there's no physical signs of an allergy, right? But when we have a more competent workforce that's more present and there's less turnover rates and they have those values and they have those ethics and they have those skills, they're able to advocate for those people that, may not use a verbal language to speak, or, because I saw another comment in there about in the question section, but like when we have those people that are in those positions and maintaining those positions, then we can have more advocacy and more knowledge about, maybe this doesn't have to do with the fact that they are on the spectrum, and it has to do with the fact that they've been traumatized. So thank you for your points, Nancy. You reminded me of that.
I also want to
Great
kind of
point.
add, I want to also add, I'm not too sure what the statistics are in regards to, I'm sure there are pediatricians who are recommending ABA therapy to their young patients or to parents for their children as a first line of intervention as soon as the parents discover their child might be autistic and they're going through an evaluation, that they're what the representation is in terms of people who might not have had any education and understand what exactly autism is, understand what mental health is. I'm speaking from my experience coming from a family that knew nothing about mental health, who knew nothing about intellectual and developmental disabilities. I didn't grow up learning any of this until I entered college. And as I meet more people in my community, specifically the Vietnamese community, I learned that I'm not alone. My family was not alone. So many of them didn't even know what autism is. They're still seeing autism as this very classic vision of what autism is. And because that's what's etched in their minds, when they come across a referral for ABA, they will absolutely take it because it would shape and change their child to appear neurotypical. And so that's still happening. And that's why I'm curious if these referrals for ABA coming from professionals is disproportionate in terms of how many are agreeing to this being the first line of intervention for their child, rather than thinking more comprehensively, something else is going on, and there are many other ways to support their child. It's not answering the question, but that's just a thought I had as this question was raised.
And this is Hector. I want to thank the parent for sharing this, and definitely takes courage to talk about what has happened to somebody. But it's very similar, like in the mental health. When you go to the doctor and you tell them you're depressed, you get a first round of medications, probably either the oldest one that they can think about, so they can start you up with something, or if they have had a pharmacy rep, they'll give you whatever the pharmacy rep recommended that day. It's an alternative. It is a choice. It is a therapy. I'm very familiar with it. I grew up with it myself. I learned about it at school. I worked a little bit in the field, and I know that for some people it's useful. For others, it's not. It's like any medication or any treatment. The only problem with this treatment is that it doesn't have the typical list of side effects that the medication has. It doesn't have some of the regulations that medications can have. It doesn't have any type of the interventions to prevent or mitigate some of the damage that can happen when you take medication, but we know that they're there. We've had people who've lived it, family members, and we know that oftentimes when people go to their pediatrician for the first time, their lack of awareness with the population and treatment modalities and therapies that actually work is one of the main reasons that they fall back on what seems to be a standard that is not officially endorsed. And a lot of people get hurt. And it is a money business, unfortunately, like everything else. Um, and I'm pretty sure somewhere out there, maybe there's somebody that's actually good. But it's like an old medication. It's like taking first generation antipsychotic that was developed in the 50s. Yeah, it's still there, but we have better things now, right? So if you're going to a doctor and this is the main thing they're prescribing, this is similar to what I tell people when they go to a psychiatrist. If you go to a psychiatrist and the first thing they do, or the only thing they do, is prescribe medication, go get a second opinion. Go get a second doctor. You deserve better. Your family deserves better. Okay. And I think it's also important for families not to be left off the hook when taking care of their children. And I say this because we've had this conversation through the vaccine conversation. Uh, it is parents' responsibility. Similarly, with seeking treatment, you know, just like you would read any medication to see if there's any side effects, listen to the people who've taken it. Did it help them? Listen to the people who are doing good. What happened to them? Don't just rely on somebody who's not really familiar with your child or your population or with your needs. Really, really ask questions, ask for a second opinion, say no, ask your family member, observe for things like that. And realize that as we get older, we do our best and we want to try not to hurt our young ones as they're growing up, because it's just one of those things. And I wish people realize that ABA is just one of those things that it's so outdated and so over abused and over glorified. If when I think of it now, I think of it as having the same type of stigma as electroshock treatment. Things have changed a lot. There are better things. We know better. So find a better doctor. Get a second opinion and also hold yourself accountable as you take care of your child and look at the ways in which you are seeking care for them. And if it's not there, join us at the table as we fight for better care. It's also your responsibility as we take care of our loved ones. And I know it's not easy, but as somebody who's now almost 50 and I'm now the caretaker for my mother who take care of me, I'm responsible to making sure that the care that she has is humane. And, and it's not easy. And it's not easy, but it is that responsibility that we take as caretakers. Okay. And you're not alone. And so is that loved one. So please do better and better. But I'm also sorry that has happened to you. And I want to thank you for sharing that because I know that there's sometimes guilt and responsibility um, that is there. And, that also needs to be part of the conversation.
Says it all. That says it all. There's a wonderful organization that might help you also, the Alliance Against Seclusion and Restraint. A lot of families whose children were very traumatized by ABA, as well as by the use of restraints, which often goes along with it, as well as seclusion. And these things are terribly traumatizing. And to James's point, I believe we need to be training frontline teachers, aides, and then those working with adults, DSPs, in trauma-informed supports, understanding the trauma that people come to us with, the trauma just of having autism, of being bullied, of being excluded, of living a difficult and challenging life, and sometimes being re-traumatized by some of these treatments that are not centered on humanity. But if that organization might be very helpful, where you can find a number of families who are experiencing the same thing and speaking out.
It's very frustrating because it's often the only thing insurance covers, and the lobbying is very powerful. ABA is sold to parents as their saving grace, the only thing that will help their children make progress. But for me personally, it's just another miracle autism cure, but in some cases dressed up in the language of neurodiversity that has been co-opted by the mainstream. I believe that everything ABA claims to provide can be better provided by other therapies without the use of behaviorism. They say we're positive now, we're just trying to increase skills. But all the skills they want to improve already have therapies working on those skills. If you want to increase ability to do activities of daily living, occupational therapy is a good choice. If you want to increase communication, get a speech language therapist who is knowledgeable about alternative communication besides verbal speech. ABA is just a worse version of other therapies that is far more behaviorist. It also puts autistic people at higher risk of abuse because they are taught that they get rewarded when they deny their own needs or do what the adult with power is asking. Just imagine how that would transfer to someone trying to abuse or take advantage of the person.
Thank you everyone for your answers. Our second question from the audience is a little long, so I'm going to summarize. The person is from Canada and says, in Canada, CBT, or cognitive behavioral therapy, is the only form of mental health care covered by the federal government, which doesn't work for everyone. What are your thoughts on this approach?
As a therapist, I myself have found that CBT can be very surface-based and can end up focusing on the behavior and sometimes even shaming people who are really having much deeper issues, if done wrong or if done in a superficial way. I have been doing EMDR type of trauma therapy for over 20 years, which I highly recommend. And I just don't think it's right for the province to be mandating the type of therapy. Also, expressive therapies are wonderful. I've done a lot of work in that realm. Everybody's different and people's needs are very vast, and they have the right. They should have the right, because they do have the right to choose. We can choose, right? So we shouldn't be restricting the type of therapy that people with disabilities get.
And this is Hector, and I think really to add to that, and I'm so sorry that Canada is like that. I don't live in Canada, and so I can't really speak as to why they have had that happen. But I do know that a cookie cutter mold for everything has never worked, and so having a variety of therapeutic choices to work with and develop are very important, and really highlighting the importance for services to be person driven, culturally responsive. Um, I actually did CBT, and it was done right by the person that did it, but that's not everybody. I'm very fortunate that she lives here, and I had a wonderful experience. But I know, having traveled across the state and the country, that the disparities in funding, the lacks of access to healthcare, the significant shortage of workforce that we continue to have, the disparities in pay for our workforce really play a significant role in the quality of services that you get. And you could you could go and have, the best care at the best hospital, but if it's done by somebody who doesn't have the training, it's not going to help you. It might actually hurt you more. And we know that this happens more and more to the most historically disenfranchised and marginalized communities. And the disability community is one of those communities, even though it shouldn't be. And so I think what I would say to that is really continue fighting for more accessibility of services. I know Canada, for a fact, is very diverse. So to have such a very limited scope of services is kind of disappointing for a healthcare system that has always been inspiring for our country. And so maybe perhaps this is where we do it better, and where we continue to thrive in that work. And I'm sure they do it too. But definitely gear for peer-driven services, community-based, community-defined best practices. Look at your traditional cultural practice services and include them in there. I really did love CBT because it gave me a different set of tools that I didn't have with just having medication. And I told you that if a doctor just prescribes you medication, get a second doctor. I did, and this doctor, actually prescribed a variety of different things, and that was the thing for me that helped, at least for me in that case. And that was the thing that helped, having choices that worked and choices that I wanted. And I think that's perhaps what Canada might need to for the developed, or all of us, because we're all very different. Medications work differently in all of us. We have most of those medications were never designed with us in mind. Definitely not women. Some of these therapies, the people that develop them come from a whole different background than we did. What they think was their struggle for us is like, oh, you're worried about that, honey. We're just worried about surviving. Talk about that. Where's the therapy for that? And so sometimes, the perceptions that people have always come with good intentions. I have to tell myself that, but ask for better, and I think, that's the one thing, demand better. If you're paying for it, if you're using your tax dollars, if your parents are paying for it, if they're using their tax dollar, you deserve to ask for more. Believe it or not, you actually can do that. I give you permission. I'll write your prescription to ask for more, for better. That's perfectly okay. And there's no diagnosis for that, unfortunately. So.
I'm not a fan of cognitive behavioral therapy. I find it isn't trauma informed because CBT assumes the person's thoughts and reactions are wrong or illogical. But if you have PTSD from abuse, the thought that someone is going to hurt you is very logical based on the person's past experience. This also applies to marginalized people. If a transgender person worries about harassment, especially in gendered spaces, and the CBT therapist says no one is actually watching you in public, it's a cognitive distortion or not a real fear. But especially in today's political climate, a trans person being afraid in a gendered space like a bathroom is completely reasonable. I feel like the only problems that CBT would actually improve in the long run are mild to moderate anxiety and depression.
I can say for myself, I have gone through the model of everyone must go through this therapy before you can get other services, and it just made my mental health worse because it did not work at all for me. I also got told in therapy that my problems weren't real and were just distortions. Health insurance, whether that be private health insurance or government health insurance, needs to cover a variety of services and needs to move past this idea that everyone needs the same thing. No one therapy is going to work for everyone, so systems need to offer and pay for different services based on what people need, not what is easiest to provide or cheapest to pay for.
and I had that experience with like DBT specifically. There were some parts of it I found very helpful, but they just assumed, oh, you're a chronically suicidal person. We're gonna do DBT because that's what we do for the people who are chronically suicidal. But like there's like the specific group therapy method of doing DBT, not just doing DBT principles. Was like there was a whole module on emotional effectiveness, but like what is emotional effectiveness when you're an autistic person who experiences the world differently? Like, I don't remember everything, but like, it just, some of the stuff they were talking about like body language and all that, it was just not applicable to my life. And like, expecting me to like be able to identify people's body language or like make assumptions about how they're feeling based on body language and stuff like that. So like that's just ableism. Like I'm autistic. Part of autism is having difficulty with social communication.
This has been a great panel. Thank you to all our panelists for their answers and our audience for their great questions. We are coming up on the end of our time, so we are going to have to wrap up. As a reminder, the recording of this panel will be posted to YouTube in the coming days. Thank you everyone for attending and have a great rest of your day.